Hello everyone and welcome to this week's NDARC webinar. I'm Olivia Price, a PhD student here at NDARC, and it's my pleasure to be hosting today's webinar. I'd like to begin by acknowledging the Gadigal and Bidjigal people as the traditional custodians of the land from which I'm joining this meeting. I'd also like to acknowledge the traditional owners of country throughout Australia, noting that our speakers and audience are joining from many different locations across Australia. We pay our respects to the elders past and present and extend that respect to any First Nations people present today. Now it's my pleasure to introduce today's speaker, Dr. Georgina Lau. Georgie is a research fellow working at the School of Public Health and Preventive Medicine at Monash University. Her research focuses on improving the measurement and prevention of injury events involving alcohol and other drugs. She was awarded a Westpac Future Leaders Scholarship in 2020 to support her research and is currently the chair of the Alcohol and Other Drugs Subcommittee for the Australasian Injury Prevention Network. Georgie's presentation today will focus on the prevention of substance-related injuries with a focus on the challenges associated with measuring alcohol and other drug involvement in injury events. I'm also excited that during question and answer time, we'll have the opportunity to hear from Associate Professor Debbie Scott from the Institute for Health Transformation at Deakin University. Debbie is a public health researcher with a nursing background, and her research interests focus on the use of surveillance systems to improve the understanding of harms associated with injury. Georgie and Debbie will take questions from the audience after Georgie's presentation, and you can ask questions for the panelists throughout the presentation using the Q&A function in Zoom. At the end of her presentation, I will ask as many questions as possible. So Georgie, I'll now hand over to you if you'd like to switch your camera on and get started.
Okay, hi everyone, and thanks Liv for that introduction. So before I begin, I'd like to acknowledge that I am presenting to you today from the lands of the people of the Kulin Nation and pay my respects to their elders past, present and emerging. So today I will be giving an overview of why substance-related injuries are such a significant public health problem, including some of the challenges that we have in measuring and preventing substance injuries within that hospital setting, as well as some of the findings from one of our recent studies at the Alfred Hospital, which looked at the prevalence of alcohol and drug detections in patients who presented specifically for non-transport injuries. So before I keep going, I would also like to take a moment to acknowledge all of the people who contributed to the research throughout my PhD. I think one of the most exciting and arguably important things to have come out of my PhD research was how it brought together people from a really wide range of disciplines. As you can see, there are a lot of people to thank, and it absolutely would not have been possible without the support and expertise from people from across a lot of institutions. In particular, I'd really like to thank my PhD supervisors, Ben, Belinda, Dev, Paul, and Sandy, as well as all the support that we had from various departments in the Alfred Hospital who really made this research possible. So to begin with, I thought I'd give everyone a bit of a quick overview of injury. I think for those of us who don't work in the injury or the injury prevention field, it can be a bit of a weird and an abstract topic. And it's really easy to be working in injury or injury prevention research without necessarily realizing that you are. And so if we go back to the very basics, injury is the exchange of energy that results in damage to either anatomical structures, so that's things like broken bones or burns, as well as physiological processes, so drowning, asphyxiation, and poisoning. And so some of the really common injury causes that we see are things like motor vehicle collisions, falls, whether that's from standing or from a height, so things like falling from a ladder or down a flight of stairs, interpersonal violence and intentional self-harm, drowning, burns, and poisoning as well. And so a lot of these things are things that quite frequently come up in the alcohol and drug research community, but don't necessarily get flagged as being injury prevention research. And so injuries can range from anything as small as a paper cut to a fatal motor vehicle collision. And we often depict this range of injury severity using a pyramid structure. So as you can see here, as we move up the pyramid, we have an increase in injury severity, but as we move down, we've got an increase in frequency. So whilst many injuries won't require people to be admitted to hospital and they might not even need treatment at all, up the very top, we have some pretty serious injuries. And I've flagged the major trauma population. That's the group that a lot of my research is focused on. So these are really serious, sometimes fatal injuries that will usually not only require patients to be admitted to hospital, but also to receive specialized treatment from a dedicated trauma team. And so these are the injuries that carry a lot of our burden. And so when we talk about injuries, we often really refer to them as kind of acute events. But that's really just the tip of the iceberg. They actually carry a really significant burden. And for those who survive, there can be really chronic ongoing health conditions that go on for years afterwards. So at the top, we often hear about those physical injuries or the fatalities, and that's certainly a very significant burden. We know that injury is the leading cause of death for people aged 1 to 44 years, both globally and in Australia. And so that's a pretty significant group of our population. But after that physical injury, we also see that there can be ongoing mental health problems, not just from the injury event itself, but also throughout the months or years it takes to recover. Ongoing physical disability, which can also involve persistent pain. And that can also impact on someone's ability to work for an income or go about their day-to-day lives as well. So in addition to that health cost, there's also all of these ongoing social and socioeconomic costs that are going on as well. And even though these injuries typically get referred to or brushed off as accidents and things that, kind of just happen by chance, this is absolutely not the case. So we know that 90% of all of these injuries can actually be prevented. And so there's this huge opportunity for us as researchers to find ways to prevent injuries from happening in the first place, or to improve the recovery of people who do get injured, to actually try and minimize this burden. And to do that, we need to address the key risk factors for injury, one of which is substance use, and it's pretty commonly accepted as well. So we know that alcohol and other drugs can be associated with a range of physiological impacts on the human body that increase the risk of injury. For example, we know that alcohol and other drugs can lead to changes in mood, things like increased aggression and irritability, increased impulsivity and anxiety, which could increase the risk of being involved in a violent altercation or intentional self-harm injuries. We also know that there are physical impacts such as blurred vision, drowsiness, and impaired coordination. And it's not hard to see how that could increase the risk of somebody having a fall or getting involved in a motor vehicle collision. We also know that it can lead to impairments in decision-making and concentration, which can increase the risk of injury as well. In addition to that, we also know that when people sustain injuries while they're intoxicated, they go on to have longer hospital stays, higher healthcare service utilization. There's a higher risk of complications. So we know that people who are injured while under the influence of alcohol might be at a higher risk of things like hemorrhage. And we also know that there's an increased risk of injury recidivism. So of all of these patients who keep coming back to hospital for injury events, 40% of them have had an alcohol-related injury before then. And so whilst this all generally seems quite obvious, both in the scientific or the academic communities and in the broader community, there still seems to be a number of really key research gaps that have negatively impacted on our ability to actually prevent these injuries from happening. And so what you're looking at here is the revised version of the public health model for injury prevention. And as you can see in the blue box, in this model, surveillance and data collection really underpins all of our injury prevention efforts. So we use data collection and surveillance as a way to not only identify risk factors, but then to develop, evaluate, and implement interventions, as well as to drive advocacy to take this research into practice and policy. But when it comes to substance-related injuries, we've really struggled to get really robust data collection and surveillance. And that has negatively impacted on our ability to advocate for all of these changes and develop interventions, because we're getting stuck right at that first step. And so some of the key knowledge gaps that we still have is that we actually have quite limited data on drugs other than alcohol and injury events. Our research to date has very much been very alcohol-centric. And when we do have research related to drugs other than alcohol, we tend to have small sample sizes. So it's not only less common, but findings tend to be a little bit more inconsistent as well. We also have very limited Australian data, especially in recent years. So a lot of our research on the prevalence of alcohol and drugs and injury events is now 10 or 15 years old, which is really challenging because we know that alcohol and drug use has been dynamic over the years. And so what was applicable 10 or 15 years ago might not be the case now. We've also seen that a lot of our current research has come from the United States. And we know that there are some pretty big differences between Australia and the US that might impact on that generalizability. We have a lower minimum legal drinking age, so we start drinking at 18 instead of 21. We've got lower blood alcohol limits for driving as well as different legislation surrounding things like cannabis. as well as firearms. So not only how we're using alcohol and drugs is different, but also the kind of injuries that we're seeing. We also have pretty limited knowledge on non-transport injury events. So we have a lot of research and a lot of data on drink and drug driving, which is absolutely needed. It's informed what are arguably some of the most successful public health campaigns, both in Australia and globally. But those motor vehicle collisions only actually make up 30% of major trauma cases in the state of Victoria. And so we still have a lot of blind spots when it comes to that other 70% of injury causes, which are causing a pretty significant impact too. And you can quite clearly see where these knowledge gaps have started to prevent us from really advocating and progressing through that injury prevention framework. A really prime example for that is our upcoming National Strategy for Injury Prevention. So hopefully this will actually get launched later this year. We haven't had an active strategy for injury prevention since 2014. And as you can see, this one that's upcoming is supposed to be for 2020 to 2030. So it has been a bit of a wait. But what is really exciting about this is that we've seen that alcohol is listed as one of 3 priority areas in this strategy. So it's actually been mentioned as what's referred to as a cross-cutting risk factor for injuries, which indicates that it is a risk factor not only for all causes of injury, but also across all demographics. But when it's come to drugs other than alcohol, we've seen very little mention of it. So the key exceptions to that are roadside drug testing, and there's also a little bit in there around poisoning and prescription opioid overdoses. So you can really start to see where these gaps relating to data on drugs other than alcohol and those non-transport injury causes are really starting to come through in our national strategies and our priorities. And so the reason why we still have so many of these gaps in the literature is because detecting substance use in injury events is really complex and it's really hard to do. There are a lot of ethical and legal considerations that we have to make. First and foremost, most of these drugs are still considered to be illegal here in Australia, so there are substantial legal and insurance implications for people who might have been injured while driving, or if they've been involved in a violent altercation, or there's been property damage. So there's a lot of things that we need to consider there in terms of how we manage that in a hospital setting. We also know that injuries have really different levels of urgency. So when we're looking specifically at that major trauma population, these are patients who are really critically injured, and it can be a life or death situation. So whilst clinicians often really recognize the importance of surveillance and identifying and addressing these risk factors, the reality is that in that critical setting, the priority is often on stopping the bleeding rather than on trying to get these surveillance measures. And at the same time, we have a lot of different measures that we could potentially use. All of them are going to have some pros and cons to them, and it's really not a one-size-fits-all situation. So we need to work out which measures are fit for purpose and are going to be best across different types of injuries and injury severities. And so first of all, when we look at self-reported measures, we can see that existing research has actually used this quite well in emergency department settings where those interactions are a little bit briefer and there's a higher turnover of patients. So in emergency settings, patients aren't as seriously injured. So we've got this really quick and inexpensive way of doing it when we use a self-reported measure. At times, we often hear that there's this risk of potential underreporting because of social desirability biases or recall biases where patients might be hesitant to say that they've engaged in alcohol or drug use. But generally speaking, in existing literature, we've seen that it can be quite a valid measure. Where it starts to become a little bit more complex is when we look towards that major trauma population because they are so seriously injured. Many of these patients will have poor memory of the injury event. They might have reduced consciousness, or they'll be have been given a lot of medications in the ambulance. And so it's not necessarily appropriate or feasible to be asking patients to self-report. And so in general, when we look in major trauma populations, we see that we tend to use administrative data, which is typically international classifications of disease coding. It's really commonly used because it's a universal measure. It's using routinely collected data, which makes it efficient and cost-effective. But we also know that traditionally, a lot of administrative data has had limitations when it comes to detecting alcohol and drug use in injury events. And so this led to one of the first studies from my PhD research. I'm not going to discuss it in too much detail, but if you're interested, the QR code in the top right will take you to the full text. In this particular study, we used data from the Victorian State Trauma Registry, which is a population-based registry that collects data on all major trauma patients in the state. And we looked at just under 3,000 patients who presented to the Alfred Hospital So what's really unique about the Alfred is that they routinely collect blood alcohol data for all patients who are suspected to meet major trauma criteria. And when we looked at these data, we found that administrative coding substantially underestimated the prevalence of alcohol in major trauma injury events. So while 4% of patients had an ICD code indicating alcohol involvement, we actually saw that 15% of patients had alcohol detected in their blood samples. And so we can see that even though administrative coding is something that we're using all the time, it's not necessarily the best measure in this particular cohort of patients who are really seriously injured. And so the challenge with this is that the coding guidelines to assign these codes actually make it really tricky for alcohol and drug use to be recorded. For it to be coded, it really needs to be quite clearly stated in that patient's medical record that alcohol or drug use has been involved. And in those busy emergency department settings, we're seeing that that just doesn't happen all of the time, and so it gets missed. The other challenge that we have here is that even though it's quite a universal measure, different hospitals and different sites have really inconsistent approaches to how they do alcohol and drug testing in injured patients. And so this coding relies on data being routinely collected, recorded, and then accurately coded, but we're seeing a lot of variation between sites. And so we've clearly seen from this study that blood testing or biological measures can be a much more sensitive measure than what we're currently using in research. But we also know that these tests aren't without their own limitations. So in terms of things like using blood or urine or saliva samples, it can be a little bit more invasive, especially if we're taking a blood sample. And we also need to make sure that those samples are collected and tested in a really timely manner because we're working within windows of detection for particular drugs. They're also relatively expensive compared to some of our other methods. But when we look specifically in this major trauma population, a lot of these barriers aren't actually as big of an issue as they are in other less serious injuries. So for major trauma patients, virtually all of them will have a blood sample taken when they arrive at hospital as part of routine clinical care. And that blood sample is used to perform a number of tests that will inform how that patient is managed. And so a lot of these barriers about having to collect a blood sample and do it in a timely manner actually aren't as big of a barrier in this particular population. However, we do know that there are some limitations here. We know that data taken from biological tests can very much be biased. So again, the full text for this study is available through the QR code, but this was another study that looked at major trauma patients in Victoria through the registry. And we wanted to see who was actually having blood alcohol tests completed and having that data subsequently recorded in the registry. And we actually saw that patients were more likely to be tested if they were younger in age, if they were injured on Friday or Saturday nights during times when we know that alcohol is more prevalent in the community, and if they had intentional injuries. So that's injuries caused by either interpersonal violence or intentional self-harm. We also saw that patients were less likely to be tested if they preferred to speak a language other than English, and if they were injured from a non-transport injury cause. And so if we're not routinely collecting these data, we can see that there's biases in who actually gets that data collected and tested, and it's not necessarily representative of the broader major trauma population. But as we've mentioned earlier, Victoria is also home to the Alfred Hospital, which is routinely collecting blood alcohol data for all of these patients. And when we restricted our analyses to patients who presented just to the Alfred, we actually saw that a lot of these biases were largely mitigated. So here we've found that biological testing can actually be a really robust measure in this major trauma population. We just need to make sure that we are doing it in a way that is routine and consistent, because otherwise we're not going to get that representative sample of really good surveillance. And so all of this research really came together in the final study from my PhD, which was focused on the prevalence of alcohol and other drug detections in non-transport injury events. So in this study, we really wanted to address some of those key gaps that I mentioned earlier by focusing in on those non-transport injury events and making sure that we had measures of not just alcohol, but also drugs other than alcohol. And so again, we focused in on patients who presented to the Alfred because they already had those routine blood alcohol tests in place. And part of this work was actually working with the various departments in the Alfred to include urine drug screens as part of that routine clinical care as well. And so as far as we know, this is the only hospital in the state that's doing both routine blood alcohol and urine drug screens. And it's also one of just 2 hospitals in Victoria where adult major trauma patients are triaged to for their care. So whilst this was a single site study, we were still capturing a fairly significant proportion of major trauma patients in the state of Victoria. So we completed medical file reviews for almost 1,500 suspected major trauma patients who had non-transport injury events. They all presented to the Alfred between July of 2021 and December of 2022. So the urine drug screens were only actually implemented in June of 2021. So this was the first time that we were able to actually look at the data from these routine urine drug screens. A quick note here as well that we did exclude patients who were transferred from other sites, just because we know that those time delays associated with transferring patients between hospitals would likely compromise the results of any blood alcohol or urine drug tests that were completed. So for a bit of context, this sample had a median age of 52 years and it was 73% male. While that does seem a little bit high, it is actually quite consistent with what we would normally see in an injury or trauma population, because we know that men get injured more frequently than women do. So as I mentioned, blood alcohol and urine drug screens were routinely ordered. In reality, we know it's a busy emergency department setting, so not all of those orders get filled. Samples were sometimes contaminated or patients were discharged before the samples and the tests were able to be completed. We also know it's quite difficult to obtain urine samples in this particular setting as well. So we had 85% of our sample with a blood alcohol test and about 50% who had a urine drug test. So when we first look at the group of patients who had either of those tests completed, we saw that alcohol or other drugs were detected in at least 38% of patients. When we focus in on that 85% who had a blood alcohol test completed, we saw that 1 in 4 patients, or 25%, had alcohol detected in their blood. And that was a median time from injury to testing of about 2.2 hours. So there was a bit of a time delay there. So if anything, we know that that 25% is a bit of an underestimate. But despite that, we did see some pretty high blood alcohol levels anyway. So the median blood alcohol level was 0.2% or 5 times the legal limit for driving in Australia. And that ranged all the way up to 0.6%, which was 12 times the legal limit for operating a vehicle. When we focus in on that 50% who had a urine drug test completed, we saw that 31% had at least one drug other than alcohol detected. And that was after a median time to testing of about 7.6 hours. So again, we know those urine samples are a little bit harder to collect and we don't normally get them as quickly as we do the blood samples. When we look at our individual drug types, we can see that cannabinoids were the most commonly detected illicit drug at 14%, followed by amphetamine-type substances at 11% and cocaine at 2%. In terms of our prescription medications, we saw that benzodiazepines were the most commonly detected at 13.4%, followed by opioids at 3.8%. So as many of you will know, it's probably not the most ideal way to dichotomize this into illicit and prescription drugs. But in this particular sample, it did enable us to look at things according to demographics, given our sample size, which I'll show you a little bit more later on. But first, I would like to highlight that one of the things that we did in this study that a lot of studies haven't been able to do was actually adjust for prescription drugs that were administered to the patient after injury, either in the ambulance by paramedics or when they first arrived at the hospital. So when we look at our opioids more closely, we can see that 40% of patients actually had opioids detected in their urine samples, but only about 4% of those were likely associated with opioid use before the injury event. We had really similar findings for benzodiazepines. So whilst 30% had benzodiazepines detected, only about 13% of those were likely associated with pre-injury use. And we can see that for both drugs, a lot of the detections that were pre-injury were in people who did have prescriptions for these medications as well. And so you can see that there's this huge potential for us to overestimate prevalence if we aren't accounting for this clinical drug use. When we look at our alcohol and drug detections by sex, we can see that it was pretty high for both male and female patients at 40 and 31% respectively. Prevalence was typically high for males, particularly in alcohol and illicit drugs, but we did actually see that pharmaceutical drug detections were higher in female patients. When we look at detections by age, we can see it was pretty high across the categories. So we're seeing that it's consistently above 40% from 18 to 54. And we really only start to see those estimates declining in those older age groups. It is worth noting, though, that as expected, we do see that those prescription drugs are generally more common in those older age groups compared to illicit drugs and alcohol. When we look at detections by injury intent, we start to see some concerningly high prevalence estimates, especially for those intentional injuries. So we saw that 47% of intentional self-harm injuries had an alcohol or drug detection, and 69% of assault or interpersonal violence injuries. I think it's also worth noting that whilst that 29% for unintentional injuries might seem low in comparison, it's still a fairly substantial proportion of patients who are testing positive. So we're still looking at close to a third of patients testing positive for alcohol and other drugs with unintentional injuries. When we look at injury cause, you can see that detections were again quite prevalent across the different groups. And I think it's worth noting that when we compare this to similar studies that have focused on motor vehicle collisions, we're seeing that alcohol and drugs are detected just as much, if not more so, than in these motor vehicle collisions. So we typically see an alcohol and drug prevalence of around 30% in motor vehicle collisions, and you can see that it's pretty similar, if not greater, across the board here. And despite that, we're still not seeing all of these other non-transport injury causes getting recognized in research and in our priorities in terms of strategies. When we look at detections by time and day of the week, we can see the detections were most prevalent on Friday and Saturday nights. It's not particularly surprising. It's during those high alcohol hours where we know that alcohol is more prevalent in the community. We still saw that illicit drug detections were high on Friday and Saturday nights, but they were actually most commonly detected on Sunday nights. I think that's probably due to the fact that we were using urine drug screens and that the most commonly detected drug were cannabinoids. So we know that there can be a bit of a delayed detection there where cannabis sticks around in urine samples for longer. And finally, for our pharmaceutical drugs, we did see that there wasn't a particularly obvious peak like we saw for alcohol or illicit drugs. And I think that's somewhat expected, given that we know that a lot of these detections were likely associated with people who had prescribed use for them. Finally, I'll just briefly mention the subset who had both blood alcohol and urine drug tests completed. So of these 718 patients, we saw that 45% had at least one substance detected. And we saw that 16.6% of these actually had multiple substances detected as well. I won't go into this one in too much detail, but it's really just here to show that alcohol remains to be the most prevalent substance detected. We saw that alcohol was detected on its own 32% of the time. And a lot of the time where we were seeing polydrug detections, it was alcohol in combination with other drugs. So finally, that said, we've had a number of limitations, the obvious one being that the detection of a drug in a blood or urine sample doesn't necessarily infer intoxication. And so I think moving forward, we really need to continue working on understanding the role that alcohol and drugs play across different contexts and situational factors, understanding what levels of drug use are actually associated with an increased risk of injury as well. So there's certainly scope to be doing case control or case crossover studies there that we never quite got off the ground during COVID, but are certainly looking towards doing in the future. We also had quite high levels of missing urine drug screen data. The in-hospital drug screens were done with immunoassays as well, so they were limited to those 6 drug classes, which prevented us from really looking at individual drug classes, as well as really differentiating between illicit and prescription drugs as well. And even though it was only one of 2 major trauma centers, it is still a single-site study, so we don't know how representative it is of the broader population. I think moving forward, we really need to look towards developing larger, more population-level surveillance systems that can facilitate more in-depth analyses. One of the things that I would have really loved to have looked at in this particular sample was doing a little bit more analysis for female patients, but unfortunately we know that they are injured less frequently and they also tended to have less detections of illicit drugs. So we didn't always have the numbers to be able to really look in depth at them. And I think if we can find ways to optimize surveillance as well, so in particular, we had low urine drug screens, but we know that those blood samples are getting collected much more frequently and consistently. So exploring the potential of using blood drug testing instead of urine testing and weighing up the cost benefit of that, knowing that blood samples are probably going to be a little bit more expensive to test. And also potentially combining some of the measures that I've mentioned earlier. So looking at how we can use self-report in combination with administrative data and biological testing to get a much more complete picture of what is going on across the spectrum of different injury severities. And if we can start to really optimize the surveillance and implement it on a more population level, we're going to get bigger data sets that we can use to actually drive all of our injury prevention efforts. So hopefully from this, you can see that substance use is very much a significant but a preventable risk factor, not just for motor vehicle collision injuries, but also across all causes of injury. But that we also still need robust population level surveillance to really drive our injury prevention efforts. I think there's also very much an ongoing need for coordinated efforts, not just in our research, but also in how we implement and develop surveillance systems that are fit for purpose and that will work in these really tricky clinical settings, as well as developing and implementing interventions for what is quite a vulnerable population, and to drive our advocacy efforts so that substance-related injuries are made a priority. So thank you so much for your time, and I think I'll pass you back to Liv now.
Thank you so much, Georgie, for such a comprehensive overview of the role of alcohol and other substances in injury. I think you did such a fantastic job of highlighting the shortcomings of our current surveillance system in Australia for injuries, and also discussing a potential path forward. Such an impressive and valuable body of work. So now I'd like to invite Debbie, our panelist, and you again, Georgie, to turn on your cameras and microphones, and we'll get started with a bit of a panel discussion about your work. Perfect. So Debbie, welcome and thank you for joining. Before we get on to questions from the audience, I just wonder if you would like to offer any reflections on the data that Georgie's presented this afternoon.
Yeah, I agree with you. It's such an impressive body of work. Georgie's a bit of a star, I think. And so much of this information is critical into feeding into what we need to know about preventing alcohol and drug-related injuries. I was surprised about the assault, the 69% of alcohol is associated with assault, thinking those are going to be the people who were injured who were also drinking. But we don't know the number of people in that then who may not have been drinking, but were assaulted by someone who was, because that person wasn't necessarily admitted to hospital. So I'm guessing that things like assault will be much higher, that the prevalence of alcohol and drug in those kinds of injuries. The other thought that came to mind is we don't have a good understanding, and even these data aren't going to give us a good understanding of where last drinks occurred. So we're not sure where people were getting their alcohol. And for a really good public health intervention, it would be great to know where they had last drinks. We could identify problem hotspots associated with pubs, and liquor licensing could be implemented, or penalties could be implemented more broadly. We could be monitoring areas where we know what the people were up to at the time they were injured, so their activity. And you probably have some of that information, right, Georgina? What they were doing at the time of injury?
We would have, but we didn't look at it in too much detail in this study.
So I'm guessing there would be a wealth of data around what was going on at the time, whether it was recreation or particularly for drowning. We know that there's really high rates of alcohol associated with drowning, and that's pretty timely.
I'll just go back to your point before, Debbie, because I actually had the same question about the role of alcohol and other substances in violence when it is part of the perpetrator rather than necessarily the victim. Do either of you know the role of any sort of surveillance systems, or how those data are collected? Is that sort of a police collection of data? Do we have good surveillance data for that side of violence and the role of alcohol and other substances?
We do have some police data on that, but it's a bit, again, not overly reliable. And we've tried in other studies to get, say, emergency departments to identify whether the person who perpetrated was drinking, or whether, and even like, say, in a road crash, the driver of the vehicle that's admitted that was drinking will capture, but if they hit someone who wasn't drinking, we don't have that data that it was an alcohol-related road crash.
Mm-hmm.
So we've tried to collect that, and emergency department staff are really loath to make those, to even collect that.
Yeah.
They don't want to make that assumption. They're worried about
Mhm.
legal implications, about being hauled into court. We see the same thing in child protection, where parents look like they might be drinking when they injure a child and the child's brought into the emergency department.
Mhm.
But the emergency department staff are really loath to identify that.
Yeah, such a sensitive area. Thank you. I'll just encourage the audience to ask any questions that they might have. Otherwise, we'll just have all my questions. So I might ask you sort of quite a specific question, Georgie, about whether you look at all like quantity, or if there's a quantity value in the presence of alcohol and drugs in people's systems that are reported through the patient records. So do you know sort of the concentration of blood alcohol level or the amount of substance that people have present?
Yeah, so we certainly get that for the blood alcohol levels. Though again, sometimes it can be really challenging because even for this, we had a median delay of 2 hours. So even then, we know that what we're seeing is probably a little bit lower than what actually happened at the time of injury. Unfortunately, with the drug screens, it was a bit of a compromise to end up using urine drug screens. We would have loved to have had blood data, which would have given us a lot more quantitative data to work with.
Yeah.
But in terms of what we got in this particular study, we just had the detected, not detected for those 6 drug classes.
And with drugs like cannabis that do stay in the system longer, do you think that as a result you've sort of seen an overrepresentation of that? Or what do you see as drugs like that as playing a direct role in the injury?
Yeah, I think cannabis in particular is the one that I really got kind of stuck on, knowing that it's likely going to be a bit of an overestimate, but
Mhm.
also knowing that we really can't say for sure that just because it was detected that it's played a role in the injury event.
Yeah.
And I think that's really hard data to actually collect, because when you talk to a lot of patients, they will say without a doubt that it had nothing to do with it, but we really don't know
Mhm.
that for certain. And I
Yeah.
think cannabis in particular is a really tricky one, because it's one that in the existing literature often has quite conflicting risk of injury, whether it actually does increase or not increase the risk of injury. And I think we really probably need to be looking at it more for specific injury causes, because whilst things like, operating a car or falls might be a little bit more increased with something like cannabis, we know that it's generally a bit more, has more of a relaxing effect, so it might not actually increase things like violence as much as we do, and we can't really lump all of those injury causes together.
And perhaps I'll ask this question to you, Debbie. Um, you sort of touched on this briefly in your reflections about using these data to inform public health preventative measures. But how do you see these data being used for prevention of injuries? Do you see sort of like similar types of education campaigns that we have for drink and drug driving, or like how do we best direct these kind of interventions?
I think there's lots of opportunities that can be very population specific. So we
Mhm.
know, for instance, that one of the biggest causes of both morbidity and mortality in older folks is falls. So by understanding what prescription medications, whether they were
Mhm.
drinking, what time of night, like do they only happen when people get up in the middle of the night to go to the bathroom? Does it happen all day? Understanding that, we can start to intervene also through GPs and specialists saying, be aware that if you
Yeah.
drink with this, it's going to have an impact.
Mhm.
I think those kinds of understandings, we know alcohol and drowning, for instance, and we've seen some of those public health messages.
Yes.
Burns are another one that I don't think we associate readily with alcohol, but it's a big influence, and it also slows the healing from burns. So alcohol and drug, we can use age specific and cause specific
Mhm.
information, and what Georgina's done has really laid the groundwork for that. So it's really important work.
Georgie, did you want to add anything to that question?
No, other than I think it's in terms of actually how we're going to address this, it's going to be a really big combination, I think, of interventions. I think what's worked really well in the drink and drug driving countermeasure space is that it's very much a public health approach, where we've had people from multiple disciplines coming together to actually implement strategies that are both targeted as well as on that bigger population level. And I think we need to really kind of take our learnings from that and try to do a similar approach more across the board in other injury causes as well.
And do you think as well with the sort of like alcohol and drug driving, there's quite an awareness, well, I think there's a bit of an awareness that your actions can have consequences on others as well, whereas for things like falls, it's sort of more about protecting yourself.
Yeah, I think it's also become socially unacceptable to drink and drive. We
Yes.
see that now. There's the public pressures come on that. So
Yeah.
and I think we see that sometimes with the one punch campaigns and things like that, where we're working. Still a long way to go. Do you
Yes.
reckon, Georgie, is that?
Yeah, I think you've kind of hit the nail on the head there, Liv, because I think the problem that we have is that alcohol and drug use is very stigmatized. So people kind of go, well, no, I would never go too far. Or I would never drink so much that I get involved in a motor vehicle collision or in a violent altercation. And at the same time, we also have people have that similar attitude towards injury where they kind of say, well, it'll never happen to me. Whereas when you have something like a violence event or a motor vehicle collision where it can involve you even when you're not drinking, I think that's when people tend to support those prevention efforts a little bit more because it's not necessarily related to their drinking or their drug use. So I think we probably have a little bit of a way to go with some of those other injury events and changing that attitude towards both injury and alcohol and drug use.
Definitely. I was also going to ask you about, I think, with sort of changes in maybe population prevalence of use of different substances, how well you think that's reflected in, sorry, this is a bit of a big question, how well you think that's reflected in sort of your injury data. So we might be seeing young people, for example, drinking less alcohol these days, or a rise in prescriptions of drugs like Adderall for ADHD. Do you think, how sensitive, I guess, do you think the surveillance systems are, or when do you think those kind of changes might manifest in those kind of data?
Go for it, Georgie.
Yeah.
Really big question.
Sorry.
I think it's tricky if we're looking specifically at the intersection of substance-related injuries. So we have really good surveillance systems for major trauma and for injuries in Australia. And we have, we've got good surveillance on our alcohol and drug trends as well, but we haven't really had consistent measures of alcohol and drug use in injuries over time, which is what makes looking at that really tricky. And I think we do have really big opportunities in the future to actually kind of piggyback off of these really good surveillance systems. We've got an Australian trauma registry, we've got the Victorian State Trauma Registry. So the infrastructure exists. It's just about integrating our alcohol and drug surveillance into that and also getting hospitals and sites on board, because we can collect the data, but unless they're collecting it and it's coming through those medical records, we're not going to have complete surveillance there either. So I think, yeah, short answer is that we have it for injuries and we have it for alcohol, but we don't have it for both of them.
Yeah, great answer to what was a confusing question, I think. And I think kind of coming off your answer to that question, what do you see as the future for surveillance of alcohol and the role of alcohol and other substances in injury prevention? Do you see, like, what are the politics between states in sort of aggregating all those data together to paint a national picture of what's going on? Debbie? Or Georgie? I
think it's probably quite a fair way in the future. I think it's baby steps. It took us 3 years to kind of get it up and running in one site. So if we could get it statewide, that would be great, and national eventually. But I think it's probably a bit of a way off, and there'll be a lot of work interdisciplinary to get it up and running across alcohol and drug injury prevention and clinical sectors as well.
I think the fact that it's now in the National Strategy for Injury Prevention as a cross-cutting issue, and before that's launched, we have to get buy-in from each of the states. So at least we'll have the states acknowledging that this is an issue. But I know from my days at Turning Point with the ambulance data, the states don't like you to compare one, like cocaine in Sydney against cocaine in Melbourne. You don't talk about it because there's a whole raft of things that are different, including how it's measured. So those are the really tricky political things, and
Yep.
governments are going to be really careful about how that goes out. So we're going to have to find a really non-stigmatizing, clear-cut way of measuring, I think.
Sorry, I'm just going through my list of questions that I was writing as you were speaking. And another one that I had was you sort of discussed the role that alcohol plays, or that alcohol was sort of the most prevalent substance across all types of injury. Are you able to control for, or do you know of any studies that have controlled for the prevalence of use in the population so that we can kind of get an idea of almost like causal which substances are more likely or carry a greater risk of injury, I guess?
I've not seen anything like that. Have you, Georgina? You're probably more up on the current literature.
I don't think I have either, so maybe something to look at in the future.
Maybe that's
It's a
a
good
question from
idea,
someone
though.
who's clearly not in the field, so isn't doing the correct research.
That's a really interesting way to think about it, though. That's something worth. Jot it
Yeah, I
down,
think.
Georgina. That's your study next.
Well, a question from the audience. So what do you believe are the barriers to major trauma hospitals implementing routine drug screening for injury presentations? You mentioned that having a routine blood and alcohol concentration screening mitigated the biases in who was measured. So this attendee is wondering why more trauma hospitals aren't doing it.
I think at the end of the day, it's kind of more related to the actual difficulties in getting something routinely put in and the costs associated with it. So a lot of them will acknowledge that it's an issue, but they are kind of saying, well, if we can identify people who are obviously intoxicated anyway, it's that attitude that if they don't want help, they're not going. Screening them is not going to make a difference. And I think what's been really different at the Alfred in terms of getting it up and running is the way that the clinicians there have really interacted with the research. And so they've really been sold on the value of actually doing this level of surveillance and how that's going to inform clinical care and future research and having that vision of being able to see that. So I think it takes a little bit more convincing to actually get the clinical side of it on board to see the benefit of doing it.
Yeah.
And hopefully as more of this research starts to come out, it'll start to become more common.
It's a great answer. There are more audience questions coming in now. Everyone's probably sick of my questions. Sorry, Debbie, did you have anything you wanted to add to that question?
No, I think Georgina's the expert on that one.
Great. So Ria has asked, has any triangulation been done with coronial data? So specifically toxicology following trauma-related deaths. She says it would be interesting to see how they compare and what gaps each approach has or could fill.
We haven't really done anything too much. We tend to see that studies either focus on the coronial side of it or the in-hospital side of it because we have very different approaches to testing. And arguably, when we look at that coronial data, we're getting much more in-depth data because they've almost all got a blood sample, which is what we weren't really able to do in the hospital setting. But I think it is something that's really interesting to look towards, and we are trying to work towards how we can actually start to look at that more cohesively.
Debbie, did you have anything to add to that one?
Nope, that's
Georgie is the expert.
she is.
And another question is, do you know why people who preferred to speak a language other than English had lower odds of having a blood alcohol test?
That was a really interesting one. And I think for us, we've seen similar studies in the US where they have found differences related to race and ethnicity. We don't have that level of data in the trauma registry, so we kind of have preferred language as a bit of a proxy. I think the other thing that we do have to be a little bit cautious of in this particular study, though, is that it was based at the Alfred, which tended to have a very distinct kind of higher SES compared to the rest of the state as well. So we've got a lot of other factors that are at play there that could potentially be biasing it. But without that kind of more detailed data, I think, about what languages, and we just don't have huge numbers for it. So it is generally a group that's quite small. So I think it's hard to really make any firm conclusions based off of that.
Yep. Well, I think that's the end Oh no. Oh yeah, that's the end of the audience question. So maybe we can wrap up, and I don't know, Debbie and Georgie, if you have some final comments you want to make, the future of substance use and alcohol in injury. What do you see the future being? What's your great hope for the future of the research?
I'll go quick and then Georgie can wrap up because it's
Mhm.
I just think it's slowly gaining recognition across a number of fields that we're going to have to find a way to work together. Because injury prevention isn't going to do it without involvement of people who do the substance abuse research and vice versa. So I think working together is the answer on it.
Collaboration.
I think Dev's stolen my final thoughts. Very similar.
Sorry,
And I
Georgie.
think it is such a complex problem, and it's one that sits across so many sectors. So I think really moving forward, we're not going to make a lot of progress unless we do start to work more cohesively and take a less fragmented approach to not just the research and the surveillance, but also the interventions. And we really need to work towards co-designing and working things together to progress through that public health approach to injury prevention.
I think that is a great final message to leave everyone on. So thank you again, Georgie and Debbie, for such an interesting and informative discussion. We really appreciate you sharing your insights with us. And I'd also like to thank everyone in the audience for joining today and engaging in the discussion at the end. But before we bring today's webinar to a close, I'd just like to let you know about our upcoming webinars. So next Thursday, the 29th of February, we have Professor Keith Humphreys from Stanford University presenting Translating Science into More Effective Addiction-Related Policies. And the following Thursday, on the 7th of March, we have a special webinar in honor of International Women's Day called Interventions for Substance Use Disorders, a Review of the Evidence. And that will be presented by Dr. Heather Valerio and Dr. Alison Marshall from the Kirby. So thank you everyone so much for joining today, and we'll see you at the NDARC webinars in the future.
Thanks.